കെയറിലെ ഏറ്റവും ആധുനികമായ സംവിധാനങ്ങളാണ് ഒരുക്കിയിട്ടുള്ളത്. മെഡിക്കൽ ടെസ്റ്റ് എവിടെ ഒരു അപകടം സംഭവിച്ചാലും മെഡിക്കൽ ടെസ്റ്റിൽ പോയാൽ രക്ഷ കിട്ടും എന്നൊരു ചിന്ത ഇത്തരം വലിയ ഹോസ്പിറ്റലുകളൊന്നും ഇല്ലാതിരുന്ന കാലത്ത് കേരളത്തിൽ വളരെ ശക്തമായിരുന്നു. ഉദ്ഘാടനം നിർവഹിച്ചായി പ്രഖ്യാപിച്ച് വാക്കുകൾ അവസാനിപ്പിക്കുന്നു.
More than 50% of the deaths are preventable. So there has been a lot of improvement and changes in the management protocols and management strategies in trauma intervention.
P. Rajit, who is a very good friend of Medical Trust Hospital. He is a well-wisher and from his college days he is associated with Medical Trust Hospital.
4-year-old, all are 24-year-olds. If tachypneic, if tachycardic. The pulse is weak and thready. The second patient.
Before the patient reaching to the hospital and probably after reaching the hospital. And very often we come across this phase of
which was done in trauma center, AIMS trauma center. Resuscitation continued in the ICU. He was put on.
Tell us that which way the patient is moving.
To open report paradoxically, this is one. Number two, if patient repeat,
the management is ABC plus management of ABC central pressure. The first and foremost
talk about what is routine.
The patient presents very early. The literature says the link if there is a vascular injury or a major near-death amputation, a major vascular injury. Limb has to be revascularized within 4 to 6 hours. That is not practically possible unless the accident happens right in the hospital.
All the things that we spoke about extrapolating hemorrhage is number one on the list on Atish said or support said. This pelvic stenting is probably the most important game changer as far as the early trauma life support is concerned.
ABC, pseudoaneurysms, fistulas, any vessel can be tackled because on CT we can pick up those lesions and immediately.
Need for massive transfusion protocol. In fact, the relationship between the pulse and the systolic blood pressure, the shock index has also been used as a better indicator of.
Trauma consultant in EMC Hospital, Amritsar. So any idea about this thing, what I'm going to do? Due to the compartment syndrome.
What is your experience about and what's your opinion about this conference? What do you feel?
As we all know, especially as trauma surgeons, we know it is literally the silent epidemic. Trauma care is the unmet need of this country.
How do you feel about this?
Workshop which is to happen now in the afternoon also will benefit a lot of the trainees to learn hands-on experience in.
Hi everyone, myself Dr. Albin. I'm coming from Apollo Adelaide Hospital, Ankamali. This session has been good. Since morning we have like several good classes going on. Afternoon session we have like hands-on training in different stations which we are seeing in our emergency department regularly.
It's a really good experience I had here. I have been working in as a casualty medical officer, but this has been a good update. I have learned some new things and the whole program was conducted very nicely.
I have been attending this program since morning, so the morning sessions were very informative, and the afternoon sessions I like the clinical exposure. I got to study about intraosseous line and more about the IMA, LMA, and the tubings.
It was very nice. The faculties were from national level, and the topic selection was also nice, and the speakers were very good, and afternoon workshop was very nice.
ആക്ച്വലി ഭയങ്കര ഹെൽപ്ഫുൾ ആയിരുന്നു ബിക്കോസ് നമ്മൾക്ക് ചെയ്യാൻ പറ്റാത്ത കുറച്ച് കാര്യങ്ങളാണ്. ഞാനൊരു ജനറൽ സർജറി റെസിഡൻ്റ് ആണ്. അപ്പം നമ്മുടെ പേഷ്യൻസിന് തന്നെ വെൻറ്റിലേറ്റ് ചെയ്യാൻ വേണ്ടി നമ്മൾ പൊതുവേ ഒരു മെഡിസിൻ PGസിനെയോ അല്ലെങ്കിൽ അനസ്തെറ്റിസ്റ്റിനൊക്കെ ആയിരുന്നു വിളിക്കാറുണ്ടായിരുന്നത്. നൗ ഐ നോ ഹൗ ടു വെൻറ്റിലേറ്റ് എ പേഷ്യൻറ്റ്.
It was a wonderful experience. Discussion onwards, it was really an academic feast. All the speakers were on time. They stuck to their topic.
Effort.